Collection of videos related to pacemakers. This collection includes basic discussion on cardiac pacemakers, pacemaker syndrome, temporary pacing, temporary pacemaker settings, leadless pacemakers, MRI conditional pacemakers, electrosurgery and pacemakers and ICD, reed switch in pacemakers and ICD, and Hall sensors in MRI conditional devices, endless loop tachycardia, and RNRVAS, pacemaker mediated tachycardias, pacemaker sensing failure ECG. Discussion on cardiac pacemakers. X-ray chest PA view showing a single chamber pacemaker with lead and an aortic prosthetic valve. The pulse generator of the pacemaker can be seen below the side marker. The pacemaker lead can be seen starting from the pacemaker header where it has been screwed in. A redundant part of the lead has been coiled within the pulse generator pocket subcutaneously, as is the usual practice during pacemaker implantation. The lead can be seen coursing through the subclavian vein into the superior vena cava and to the right atrium. Distal end of the pacemaker lead can be seen to the right of the spine near the left hemidiaphragm. The fact that the lead has crossed the midline in a PA view indicates that it has crossed the tricuspid valve, which usually overlies the spine in this view. Permanent right ventricular pacing leads are often placed at the right ventricular apex, which is technically easier. Several implanters now consider a position in the right ventricular outflow tract as more physiological. While pacing the right ventricular outflow tract, a screw-in lead is needed to retain the position. Special lead stylets are available to negotiate the lead tip to the right ventricular outflow tract. Position in RVOT should be posteriorly in the septal aspect, avoiding the free wall of RVOT to achieve the objective of early entry of signal into the conduction system. Early entry of signal into the conduction system will reduce dyssynchrony, which has been considered as a downside of right ventricular apical pacing. Close scrutiny of the pacemaker lead tip can identify two electrodes, one at the tip and one a little proximal to that. It needs a higher resolution photograph with more penetration or ideally a fluoroscopic imaging to bring out the details of the lead tip well. This X-ray also shows a star-Edwards aortic mechanical prosthetic valve and sternal suture wires. The aortic position of the valve can be identified by the upward direction of the cage. In star-Edwards aortic processes, the cage is seen upwards with 3 struts and the sewing ring at the base. This contrasts with the mitral processes, which has 4 struts for the cage and the cage is directed downwards towards the left ventricular apex. A prominent aortic knuckle and a bulge of the right atrial contour are other findings on this chest X-ray. Cardiac pacemaker is a device meant to give regular electrical pulses to the heart when the normal pacemaker function of the heart is defective. It is also used when the pulse conduction to the ventricles is blocked, as in complete heart block. Basic electronic pacemaker consists of an electronic circuitry to generate the pulses, a battery with long storage life of several years, and leads to convey pulses to the heart. Battery and circuitry are housed together in a hermetically sealed metallic container made of biocompatible material which will not induce a foreign body reaction in the body. This part, known as the pulse generator, is usually implanted beneath the skin under local anesthesia. Modern pacemakers have highly complex circuitry capable of monitoring the body's requirement and varying the pulse rate accordingly. They are also communicating devices which can transmit the stored information to a device known as programmer kept over the surface of the skin. Programmer can interrogate the pacemaker to retrieve important information regarding pacemaker function and malfunction. Latest programmers can send the data to a server over the internet, making it feasible for the specialized physician to evaluate complex pacemaker function sitting in another country or continent. The pacemaker lead is a passive component which transmits the pulses to the heart and receives the heart signals for the pacemaker to analyze. The current day demand pacemakers will sense the heart's intrinsic activity and give pulses only when they are not present. There are pacemakers available which can pace 1, 2 or 3 chambers of the heart. They are known as single chamber, dual chamber and biventricular pacemakers respectively. X-ray chest PA view demonstrating dual chamber pacemaker with leads in situ. Tip of the atrial lead is seen in the right atrial appendage location. It is a J-shaped lead which is preformed to reach the right atrial appendage. The ventricular lead tip is seen in the region of the right ventricular apex and appears to be a screw-in lead. The dual chamber pacemaker pulse generator is seen in the left infraclavicular region. The leads are seen traversing the left subclavian into the left brachiocephalic vein to the superior vena cava and then to the right atrium and right ventricle. Dual chamber pacemakers are able to provide multiple modalities of pacing. The atrial lead senses the atrial electrogram if present and triggers the ventricular channel after the programmed atrioventricular delay. This ensures atrial health for ventricular filling and improves cardiac output. Electronic circuitry of the pacemaker can interact with electromagnetic radiation. Keep away from sources of heavy electromagnetic radiation like a powerful radio transmitter. Most other day-to-day devices can be used with certain precautions. Theft detection devices can also cause electromagnetic interference. Mobile phones can be used at a distance. The usual recommendation is to keep it on the opposite ear depending on which side the device has been implanted. Those with implanted devices are given an identification card which can be shown at airport and other similar locations where electromagnetic devices are likely to be used for security check. MRI in pacemaker patients was generally regarded as contraindicated till recently because of potential interactions between the electromagnetic field and the device. Important aspects to be considered are as follows. 1. Local tissue heating. Device leads pick up energy and transfers it to the cells, causing rise of temperature. 2. Arrhythmia induction. Abnormal heart rhythms can originate due to the interference of device function. 3. Malfunction of device software and hardware due to interference by the magnetic field. 4. Artifacts due to the presence of the device in the image, decreasing the diagnostic accuracy of magnetic resonance imaging. Newer MRI conditional devices enable better imaging on following certain preset criteria and precautions. MRI is undertaken in pacemaker patients only if the estimated benefit far exceeds the potential risks and equivalent information is not obtainable by other imaging modalities like ultrasound or computer tomography. Here is the reference to my previous journal article on MRI conditional pacemakers. Mitsui and associates were the first to describe pacemaker syndrome in 1969 as a symptom complex associated with right ventricular pacing. In general, pacemaker syndrome is due to a loss of AV synchrony and it is relieved by AV sequential pacing. But of late, the role of VV synchrony has also been highlighted so that efforts to minimize right ventricular pacing has been promoted. Patients with pacemaker syndrome may present with exertional dyspnea, hypotension, near syncope or even syncope. Syncope occurs in the setting of a drop of systolic blood pressure more than 20 millimeters of mercury at the onset of ventricular pacing. Easy fatigability, sensation of fullness and pulsation in the head and neck are also features of the pacemaker syndrome. When an intact VA conduction is present, the pacemaker syndrome may be more severe due to the reverse atrial kick associated with every cardiac cycle. Venous pressure elevation as a result of atrial contraction against a closed AV valve causes reflex peripheral vasodilatation and hypotension by stimulating the vagal efferents. The reported incidence of pacemaker syndrome varies widely. In those trials in which a dual chamber pacemaker was implanted and programmed to single chamber mode for the study purpose, The changeover rates to dual chamber mode for suspected pacemaker syndrome was high. But in those trials in which a surgical revision was required for a mode change, the reported incidence was low. This may indicate a lower threshold for the diagnosis of pacemaker syndrome when surgical revision is not required. Here is the reference on original description of pacemaker syndrome. Discussion on temporary cardiac pacing. Temporary pacing is a life-saving procedure for maintaining the heart rate when it falls markedly, producing features of cerebral hypoperfusion. It can also be done prophylactically during certain procedures when there is a possibility of sudden fall in heart rate. Other reasons for temporary pacing are pacing to overdrive a tachycardia like ventricular tachycardia and pacing at fast rate to stabilize an aortic valvuloplasty balloon during balloon valvuloplasty. Temporary pacing is done prior to permanent pacing to give a good bradycardia support during the procedure. This fluoro shot is that of a temporary transvenous pacing through the femoral vein. The pacing lead is introduced through percutaneous puncture of the femoral vein in the groin. Lead is introduced under fluoroscopic guidance through the inferior vena cava and right atrium into the right ventricular apex. Pacing threshold is checked using the pacing system analyzer or a temporary pacemaker, and the output kept 2 to 3 times above the threshold to ensure regular pacing. Externally, the pacing lead is fixed to the skin to reduce the chance of migration. Temporary transvenous pacing can also be done from the jugular, transjugular pacing, or subclavian routes by percutaneous puncture. Pacing maneuvers are an integral part of an electrophysiology study. In this case, pacing is done from various locations, unlike the usual right ventricular pacing for bradycardia support. Proximal connectors of a pacing lead are shown in this image. Tip of the bipolar temporary pacing electrode has a distal tip electrode and a proximal ring electrode. It is customary to give negative polarity to the tip and positive polarity to the ring electrode, as cathodal pacing has a lower threshold. Threshold is the minimum voltage needed for capturing the chamber paced. Here the tip has a golden color and proximal ring electrode has a silver color. But this is not a universal color code. Some temporary pacing electrodes have same color for both electrodes. Transvenous pacing can also be done at the bedside using balloon-tipped flow-directed catheters introduced by a subclavian puncture. Electrocardiographic monitoring from the tip of the pacing lead can guide us on the chamber in which the lead tip is positioned in the absence of fluoroscopy at bedside. While the tip is in the right atrium, large atrial deflections are recorded, and the pattern changes to an intracardiac ventricular electrogram when the lead tip reaches the right ventricle. Pacing through coronary artery is done as an emergency measure when a patient develops severe bradycardia during a coronary intervention procedure if a temporary transvenous catheter is not already in place. The proximal end of the coronary guide wire can be connected to the temporary pacemaker using a crocodile clip. A needle stuck into the skin can serve as the second electrode. This saves time needed for achieving an urgent femoral venous puncture and sometimes the potential bleeding risk of such punctures in a person who is fully anticoagulated for the coronary intervention. Pacing in an emergency situation can be obtained in the intensive care unit using external pacers which pace through large adhesive electrode patches applied to the chest wall. The disadvantages of transcutaneous pacing are the large current needed and consequent pain due to skeletal muscle stimulation, as well as the often unreliable ventricular capture. At the most, it can be used in standby mode to buy time for arranging a transvenous pacing. ECG shows a pace rhythm at around 60 per minute with pacing spikes preceding each QRS complex. At first look, it may seem that there is P wave before each QRS with a reasonable PR interval suggesting atrial sensed ventricular pacing, A-sense, V-pace, sequence or tracking. But close scrutiny shows that PR interval is gradually varying. The atrial rate is also close to 60 per minute, making false appearance of an AV synchronous pacing in some beats. In analog ECGs, the pacing spikes in temporary pacing are usually small as the pacing is bipolar with both electrodes within the ventricle. In digital ECGs, such small spikes are usually wiped out by the filter settings and the ECG appears like a left bundle branch block pattern. But switching on the pacing detection algorithm in digital electrocardiographs enhances the pacing spike detection, and sometimes the spikes are prominent even with temporary bipolar pacing, as in this case. Otherwise, a large spike indicates unipolar pacing between pacemaker can and lead tip electrode, which can occur only in a permanent pacemaker. The temporary pacemaker cover is non-conducting and situated outside the body without electrical contact. The QRS pattern mimics LBBB pattern with left axis deviation, as is usual with right ventricular apical pacing. If the lead tip slips and paces the right ventricular outflow region, it will give an LBBB pattern with inferior axis. Right bundle branch block pattern, if it occurs in the setting of temporary pacing, may indicate lead tip perforating either the interventricular septum and pacing the left ventricle endocardially, or the right ventricular free wall and pacing the left ventricular epicardium through the pericardial cavity. Here the interval between the pacing spike and the QRS complex is very short, so that there is good conduction at the lead endocardium interface. If that interval is prolonged, it would indicate a first degree exit block at the lead endocardium interface, pacemaker ventricular block. If the block is severe, it can lead to intermittent pacing, second degree pacemaker ventricular block, or loss of capture, exit block. Here is a reference on pacemaker ventricular block. This is an accompanying video for the previous video on temporary pacing available on this channel. This video will describe the basic temporary pacemaker settings. The controls and buttons shown here are symbolic and vary between different models of the pacemakers. Some pacemakers have a display of the modes and parameters in addition. This description is on commonly used single chamber temporary pacemaker. Dual chamber temporary pacemakers will have additional controls and displays. We will start off by switching on the pacemaker using the on-off button. The display lights up in case of pacemakers with a display panel. In simpler devices, a power on indicator will light up as well as a battery indicator. Pace sense indicator will start blinking at the set pacing rate. If there is a spontaneous rhythm sensed, the color of the blinking indicator light will change to a different set color, usually green. The lock button is used to lock the settings to prevent inadvertent changes in pacemaker parameters. It can be unlocked when needed to change the settings. Pacing rate can be set as per the patient's physiological need. There will be dual rate controls in dual chamber pacemakers, one each for atrial and ventricular channels. For fast overdrive burst pacing, there can be an additional 2x control button. Pressing the button will quickly double the pacing rate. This is useful sometimes for overdrive pacing to break tachycardias. Pacing output setting is decided after testing the pacing threshold. Threshold is checked by gradually reducing the output till the pacing capture is lost and then quickly raising it back. Usually output is set at 3 times the threshold for temporary pacemakers. Higher safety margins may be used if the person is restless and likely to have lead displacements. Threshold should be checked at least once daily to ensure good safety margin. While checking for threshold, sometimes the presence of spontaneous rhythm may be detected. Otherwise, we can check for spontaneous rhythm by gradually reducing the pacing rate. Once sinus rhythm with fair rate is detected, keep the pacing rate at a lower backup rate for emergency. It is customary to observe for one more day before removing the temporary pacing lead, but this may vary depending on the stability of the spontaneous rhythm. Sensitivity control is used to adjust sensitivity sufficient to detect a spontaneous rhythm and inhibit unnecessary pacing. If sensing at very low voltage is set, T-wave oversensing and pacing inhibition may occur. If sensitivity is kept at a high voltage, pacemaker will not sense properly and function in asynchronous VOO mode. This can lead on to R-on-T phenomenon and dangerous ventricular arrhythmias. Discussion on leadless pacemakers. Weakest link in the pacemaker system is considered to be its lead, sometimes called its Achilles heel. This is because the lead system is prone for infection, fracture, failure and dislodgement. The more the number of the leads, the more the complications, as in sophisticated systems like dual chamber pacemakers and biventricular pacing devices. The incidence is compounded over time with longevity of the device and the recipient. The risk of lead extraction is also significantly high in case it is needed, hence the need for a leadless pacemaker system. Micra transcatheter pacemaker system can be delivered percutaneously using a delivery system via the femoral vein. It provides right ventricular sensing, pacing and rate responsiveness. It uses an accelerometer sensor for rate responsiveness. The device is delivered in the right ventricle. Micra transcatheter pacing study group successfully implanted the device in 719 of 725 patients enrolled for a multi-center study. Primary safety endpoint was freedom from system-related or procedure-related major complications. Primary efficacy endpoint was percentage of patients with low and stable pacing capture thresholds at 6 months. Cutoff was 2 volt or less at a pulse width of 0.24 milliseconds and an increase of 1.5 volts or less from the time of implantation. Major complications were compared with those in a control cohort of 2,667 patients with transvenous pacemakers from 6 studies published earlier. Rate of primary safety endpoint was 96% and primary efficacy endpoint 98.3%. Complication rates were significantly lesser than the historical control cohort. A feasibility study of accelerometer-based atrioventricular synchronous pacing with a ventricular leadless pacemaker was published in 2018. Micro has a 3-axis accelerometer. They developed a custom software to detect atrial contraction using the accelerometer to enable AV synchronous pacing. The Marvel study tested the algorithm downloaded into previously implanted Micra devices. AV synchrony was defined as visible P wave on surface ECG followed by a ventricular event in less than 300 milliseconds. A total of 64 patients in 12 centers across 9 countries were evaluated. Patients were implanted with a Micra for a median period of 6 months. 33 had high-grade AV block while 31 had intrinsic AV conduction during the study. Average duration of AV algorithm pacing was 87% in those with high-grade AV block. 94.4% AV synchrony was noted in those with intrinsic conduction. Here the pacemaker senses the mechanical activity of the atrium rather than the electrical activity which is sensed by conventional AV sequential pacemakers. In an innovative case report, a new leadless pacemaker was synchronized with an existing transvenous atrial pacemaker. Patient had sinus node dysfunction and intermittent Morbid's type 2 AV block, for which a dual chamber pacemaker was implanted earlier. Pacemaker interrogation after syncopal episode showed right ventricular lead threshold of 5.5 volts at a pulse width of 1 milliseconds. There was only less than 1% right ventricular pacing, and there was a previously documented chronic malfunction of right ventricular lead with impedance more than 3000 ohms. Atrial lead was stable with intact parameters. Patient was on hemodialysis using a left arm arteriovenous fistula for end-stage renal disease. Hence, risk of bleeding and infection for lead extraction and implantation of a new lead on the left side was deemed high. Considering all aspects, they decided to go for a leadless pacemaker and a Micra AV was implanted. Previous pacemaker was programmed to atrial pacing, atrial sensing, inhibited mode. Micra AV was synchronized to the atrial contraction resulting from atrial pacing of the previous transvenous pacemaker. Thus, the patient had two pacemakers interacting to produce AV synchrony after careful programming. A systematic review and meta-analysis on safety and efficacy of leadless pacemaker has been published. They identified 36 observational studies of nanostim and micra leadless pacemakers, of which 69.4% reported outcomes for micra. In 5 studies with 1-year follow-up, micra was associated with 51% lower odds of complications compared with transvenous pacemakers. 98.96% of the 1,376 patients implanted with micra had good pacing capture thresholds. They concluded that studies report outcomes for micra associated with a low risk of complications and good electrical performance up to 1 year after implantation. They opined that further randomized controlled trials are needed to support the widespread adoption of these devices in clinical practice. Discussion on MRI conditional pacemakers, including safety of 1.5 Tesla and 3 Tesla MRI scans. Conventionally, MRI is contraindicated in those with implanted pacemakers due to possibility of electromagnetic interference with pacemaker function. MRI conditional means that there are no known hazards when MRI is performed with pre-specified device programming, patient monitoring, and imaging protocols. MRI conditional pacemakers were first introduced in 2008. These pacemakers have less ferromagnetic material and lead design changes reduce the chance for heating. Reduction of ferromagnetic material also reduces the potential for artifacts induced by the pacemaker system in the MR images. The winding pattern of the filament of inner lead coil and geometric design of the leads have been changed to avoid resonance at the MR signal frequency to avoid heating. It may be noted that MRI conditional devices should be connected to MRI conditional leads only. Otherwise, the system will not be MRI conditional. Reed switch is replaced by a solid state Hall effect sensor which perform better within the MR console by avoiding unpredictable reed switch behavior. Reed switch behavior will vary with the strength of the magnetic field and the orientation of the reed switch in the field. Easily programmable MRI mode is available in these devices. This will prevent inappropriate pacemaker inhibition and competing rhythms. These devices have special circuitry to prevent damage to internal power supply when exposed to MRI signals. ASTM standard F2503 for making medical devices and other items for safety in the magnetic resonance environment. From the left to right, the symbols for MR safe, MR unsafe, and MR conditionally safe. Wilkoff and colleagues in a prospective randomized controlled worldwide clinical trial evaluated the safety and effectiveness of MRI conditional pacemakers in 464 patients. Patients were randomized to undergo MRI scan between 9 to 12 weeks after implantation of specially designed dual chamber pacemaker and leads. MRI was done at 1.5 Tesla and patients were monitored for arrhythmias, symptoms and pacemaker function. Brain and lumbar MRI sequences were obtained. No complications related to MRI occurred during or after the scan. Pro-MRI Phase B study was a multi-center prospective non-randomized study to evaluate the clinical safety of the Biotronic Pro-MRI pacemaker system in patients undergoing thoracic spine and cardiac MRI. The study enrolled 245 patients with stable baseline pacing. 216 patients completed the MRI scan and 1 month follow-up. One adverse event possibly related to the implanted system and MRI procedure occurred. The serious adverse device effect-free rate was 99.6%. Real-world data of 4-year prospective follow-up in 2,629 patients with MRI conditional pacemaker system has been published by Williamson and Associates. 526 patients underwent 872 clinically indicated MRI scans, including 58 thoracic scans. No MRI-related complications occurred during or after MRI. 6 MRI-related observations were reported, which included atrial fibrillation, increase in pacing capture threshold, and chest symptoms. 171 patients underwent 2 or more scans with no cumulative increase in pacing capture threshold. MRI using 3 Tesla devices has been reported by Ning and colleagues. 20 patients with MRI conditional pacemakers underwent 23 MRI scans of different regions of the body, including brain, lumbar spine, cervical spine, and heart. Standardized protocol was developed by cardiologists, pacemaker engineers, and radiologists. No adverse events were detected and image quality was grade 1 in 16 patients. Artifacts of pulse generators and leads in cardiac MRI scan caused grade 2 quality in 4 patients without any impact on diagnostic value. Here are the first set of journal references on MRI conditional pacemakers. Second set of references on MRI conditional pacemakers are here. Last reference is here. Discussion on electrosurgery in patients with pacemakers and ICDs. Electrosurgical equipment uses radiofrequency energy in the range of 0.1 to 5 MHz. This can cause electromagnetic interference with pacemakers and other cardiac implantable electronic devices. In general, if the use of cautery is below the umbilicus with the indifferent electrode patch kept beneath the thighs, the chance of interference with the thoracic CIED is unlikely. Electrosurgical equipment can have unipolar and bipolar modes of operation, the former being more frequently available. In unipolar mode, the current flows from the cautery tip to the indifferent electrode kept behind the body. In bipolar mode, the current flows between 2 electrodes at the tip of the cautery probe. Bipolar mode is safer in the presence of a pacemaker, less likely to cause EMI. Maximum chance of EMI is when the cautery is used within 8 cm of the CIED. If there is interference noted with the device during the procedure, like inhibition of a pacemaker, using cautery in short bursts will be useful to prevent life-threatening asystole. Another option is to reposition the ground electrode of the electrosurgical equipment to redirect the current path away from the implanted device. Pacemakers are programmed to asynchronous mode, and implantable cardioverter defibrillator tachyarrhythmia therapies are suspended prior to surgery if interference is likely. If the patient is not pacemaker dependent, pacemaker can be programmed to a low backup pacing rate in addition. CIED programming is done before and after the surgical procedure to ensure proper functioning of the device. If device programmer is not available in an emergency, taping a magnet over the device will suspend ICD shocks and switch the pacemaker to asynchronous mode. Magnet can be removed after the surgery to resume normal function. This discussion is on reed switch in pacemakers and implantable cardioverter defibrillators. Includes a mention on its replacement by Hall sensor in MRI conditional devices. Reed switch is used to activate the magnet mode in pacemaker or implantable cardioverter defibrillator. It is basically a collection of 2 strips of magnetic material enclosed in a glass capsule. Application of a magnetic field closes the reed switch by making contact between 2 metal strips. This changes the sensed voltage in a sensing amplifier, triggering a circuit controlling the magnet mode functional status. Reed switch can malfunction if the glass capsule is broken, remaining in same position regardless of the applied magnetic field. This situation is called sticky reed switch. The exact effect of magnet application on the various functions of pacemakers and ICDs will depend on the make of the device and the programmed parameters. But in general, the effect on pacemaker is that it stops sensing and functions in an asynchronous pacing mode. In case of ICDs, magnet application suspends all anti-tachycardia therapies without affecting the pacing mode. In most pacemakers, magnet application increases the pacing rate during the asynchronous pacing mode, but the actual rate and duration for which the higher rate is maintained will vary with each manufacturer or model. Some pacemakers can be programmed to initiate vario threshold checking on application of a magnet. Older pacemakers have a reed switch to initiate the magnet mode, while newer devices have a Hall sensor. Hall effect sensor is the modern replacement for the reed switches in pacemakers and ICDs. It is used in MRI conditional devices. Hall effect is a generation of electrical voltage across a conductor when the magnetic field is perpendicular to the direction of current flow in the conductor. In MRI conditional devices, the Hall effect can be used to lock out the device during the scan. Limitations of reed switch. Reed switch behavior will vary with the strength of the magnetic field and the orientation of the reed switch in the field. Reed switch is replaced by a solid state Hall effect sensor which perform better within the MR console by avoiding unpredictable reed switch behavior. Discussion on endless loop tachycardia and repetitive non-reentrant ventriculoatrial synchrony. Endless loop tachycardia is the commoner of the two types of pacemaker mediated tachycardias, the latter being repetitive non-reentrant ventriculoatrial synchrony. Endless loop tachycardia is repetitive reentrant ventriculoatrial synchrony. In RNRVAS, pacemaker does not sense the retrograde P waves. In this form of ventriculoatrial synchrony, the atrial stimulus is ineffectual because it falls within the atrial myocardial refractory period generated by the preceding unsensed retrograde P wave. This leads to a long atrioventricular interval, and when there is a relatively fast lower rate or sensor-driven rate in DDDR pacing, leads to atrioventricular desynchronization arrhythmia with unfavorable hemodynamics. Here is an ECG with paced rhythm and retrograde P waves. It can be seen that VA interval is short and AV interval is long, which gives rise to unfavorable hemodynamics. In fact, there will be regular cannon waves in this case of VVI pacing. In pacemaker-mediated endless loop tachycardia, the pacemaker actively participates in the tachycardia circuit. This occurs only in dual-chamber pacemakers. The ventricular depolarization is conducted retrogradely and is sensed by the pacemaker circuitry. This triggers a ventricular pacing stimulus at the end of the programmed AV delay. The ensuing ventricular beat is again conducted back into the atrium and the vicious cycle continues. Final result is a tachycardia at the upper rate interval of the pacemaker. The tachycardia is usually triggered by a ventricular ectopic beat, which fortuitously has an appropriate timing for initiating the vicious cycle. Sometimes endless loop tachycardia can also be initiated by an atrial ectopic beat occurring within the post-ventricular atrial refractory period. Pacemaker-mediated endless loop tachycardia is usually terminated by magnet application, and it can be prevented by programming the P-warp appropriately. Though usually the tachycardia is terminated by application of a magnet, one unusual case in which it was induced by magnet application and persisted despite repeated removal and reapplication of magnet has also been reported. If a pacemaker programmer device is not available, pacemaker-mediated endless loop tachycardia can also be terminated by chest wall stimulation to inhibit the ventricular channel of the dual chamber pacemaker. A study evaluated chest wall stimulation by an external pulse generator used for transcutaneous pacing, provocation of myopotential oversensing, and chest thumping for termination of endless loop tachycardia. Chest wall stimulation was applied in 10 patients with unipolar and 10 patients with bipolar DDD devices during endless loop tachycardia and was successful in terminating all cases. Myopotential oversensing could terminate endless loop tachycardia in 6 out of 10 cases and chest thumping terminated 4 of 6 cases. Occasionally, pacemaker mediated endless loop tachycardia gets converted to RNRVAS and is one of the reasons for magnet unresponsiveness. What are the findings in this ECG and possible explanations? ECG shows PR interval prolongation, Q and ST elevation with T inversion in lead 3, small q and T inversion in AVF, along with lateral ST depression and T wave inversion, indicating an infralateral myocardial infarction with first degree AV block. The interesting part is evident in the rhythm strip. Multiple pacemaker spikes or pacing artifacts are visible. The spike marked with blue arrow has come a short while after the preceding QRS complex and has captured the ventricles, causing a white QRS complex. The premature occurrence of the pacing spike would indicate a sensing failure of the pacemaker. The pacing artifact marked by red arrow has occurred prematurely and has failed to capture the ventricles. The premature occurrence indicates sensing failure. Though it has not captured the ventricles, it does not mean capture failure, as it has occurred within the QT interval of the previous QRS complex when we expect the ventricles to be refractory. Rhythm strip shows 2 additional pacing spikes with ventricular captures also occurring fairly early after the previous QRS complex. Early occurrence again indicates sensing failure. Usually, demand pacemaker waits for a pause in the basic rhythm before firing, as it senses the spontaneous rhythm and works in inhibited mode. Inhibited mode means that a sensed impulse will inhibit the pacing. In the setting of evolved inferior wall infarction, it is likely that temporary pacing was done for complete heart block, which has now resolved into first degree AV block. Possibility of lead displacement has to be considered, which is more likely with temporary pacing. Thank you for watching this video. Please subscribe, like, share, and post your valuable comment below this video.